Good morning. Our speaker this morning is Dr. Yaron Moshel. He is the co-director of the Glasser Brain Tumor Center at Atlantic Health Overlook. In other words, he's a brain surgeon. And there have been extraordinary advances in this type of surgery over the last several decades. And frankly, some of them are utterly amazing. And Dr. Moshel is going to share some of them with us. Dr. Moshel.
Thank you. Okay, so we're set. Well, thank you everyone for having me. Hopefully I won't bore you too much, but I'd be happy to go over the Brain Tumor Center and what we do. The Brain Tumor Center was really founded out of Overlook Hospital, where I spent the majority of my time. And when I first came here, now it's been a long time ago, one of my passions was always brain tumor surgery. And one of the things you learn is, surgeons are very technical, and we're technicians to some extent, but really we have to treat the entire person. And I thought that was missing. And so one of the early things that was important to me was to bring all the specialists together that really can treat the entire person. Because what is it that makes us a person? And not to get too philosophical about it, when you get diagnosed with a brain tumor, it's really a life-changing event. Your life changes in a second. You have a physician telling you you have a brain tumor. It could be benign, it could be cancerous. It's very different than having a mole on your hand or even a lesion in your esophagus. Our brains make us who we are, and it quickly becomes this existential crisis. And to take care of someone who has a brain tumor, you need a whole team. You don't just need a surgeon who can do all sorts of technical stuff, but you really need a team of people. And that's what we try to organize. So this is just an example of us having fun, but what we really brought together were neurosurgeons, neuro-oncologists, and radiation oncologists, and together with that, a whole lot of technology to deliver integrated care. So we got the Glasser family actually donated the seed money to start the Brain Tumor Center, and the mission was to bring together a team. This is the early version of the team, and the team quickly grew into a group of people, including nurse navigators and social workers. We even have retired physicians who serve as hospice counselors who will go and do home visits to families. And eventually the center grew into a larger entity that spans all of Atlantic Health. But the key tenets are neurosurgery, radiation oncology, and neuro-oncology. And we've gotten a bunch of awards, but that's I'll skip over that. The one question people ask is, well, okay, what are you really treating? What is this brain tumor business? And there's quite a variety of types of brain tumors. There are benign tumors, such as meningiomas and pituitary tumors. And then there are malignant tumors, which the most common ones are metastatic tumors that come from other parts of the body. And probably the hardest to treat are gliomas, which are tumors that originate within the brain. And we'll go into a little bit about some of the research that's going on behind that. But the first piece of it is the technology. How do we do brain surgery today? It's really evolved. I'll go over some of the technical things. And also the non-surgical stuff. So CyberKnife, this is the CyberKnife machine at Overlook Hospital. It's this big robotic arm that basically swivels around the head, and it allows us to non-invasively, I use the word zap. We zap these little tumors. So imagine someone who has, in this case, 6 or 7 tumors. Probably 15 years ago, this was someone we couldn't treat. But today, we look at this and we say, that's not a problem. You don't even need surgery. This can be treated with CyberKnife completely non-invasively. And I think I have an example here. What the robotic arm does is it swivels around the person's head, and the person's head gets immobilized with a little mask. But the idea is it delivers these tiny little beams of radiation in a way that's monitored by a computer system so that all those beams crisscross right at the tumor. So in this picture, you can see here these beams, if the person's accurately placed within the machine and the robot moves very accurately, you can actually zap individual little beams, little tumors like this, completely non-invasively. And what actually happens is, by and large, most of them, smaller ones, will disappear. And that's a great adjunct that we have to, again, to avoid surgery, or in people who've had surgery, to treat other lesions that pop up. This is an example of a young person. Just earlier, someone mentioned something about COVID. She was a great story. She's a woman who had neck pain. She had this large tumor. You see this white structure here, and that's at the back of the spinal cord and her brainstem. And during COVID, she essentially toured the coastline of New Jersey trying to find someone who listened to her. But at Overlook Hospital, when everything was shut down, we actually were able to do her surgery. And she spent the entire hospital stay in a little cubicle that was, curtained off. And she stayed there for 2 or 3 days, but it saved her life. Just to give you a story of the kinds of amazing things that were done during the height of COVID. So what are some of the advanced techniques that we have? Well, one thing is, to do surgery well, you need to be able to see well. And to see well, you need a very high-end microscope. It sounds simple, like it's just microscopy, but microscopes today are actually very different. They not only show you the brain anatomy, they show you functional anatomy. So in this case, this person had an injection of a fluorescent dye in the bloodstream. So as we do the operation, you can actually see each blood vessel light up around where you're working to make sure that those arteries are still patent after the surgery. That's very important to know so you don't cause a stroke in that part of the brain. This is an example of, we now have the microscope can actually hover over the patient, but we all wear 3D glasses, and we actually can do the surgery in 3D. It's almost like a virtual reality experience. It's kind of cool. It allows for more people to participate in the surgery. It allows us to look at things from different angles. And also, as a surgeon, you're not stuck doing the entire operation, looking down and hurting your neck. Some of these surgeries can be 10, 12-hour surgeries. The other piece that the microscope does is it has integration with what we call stereotactic guidance. So over here in this picture, what you're seeing is, that's me doing surgery, but back over here on that computer screen, you see it's almost like a GPS system that allows us to track where in the brain we are. And that's what we call navigation. And that's not a particularly new idea. That's the same idea that the CyberKnife machine uses to accurately zap these little tumors. But we use navigation in surgery to plan surgery. And the philosophy there is, I tell patients, I can't make you Superman. If I see your normal brain, I can't help it. I can only hurt it. So less is more. If we can design openings in the head that are exactly the size of the lesion that you're trying to remove and no bigger, and sometimes we have a lot of patients with incisions that are about 1 inch long, and that's it, to remove these tumors. They recover faster. Those people leave the hospital the next day sometimes. Whereas if you kind of have the older philosophy of, I want to be comfortable, I want to see everything, let's just expose everything and be safe, which is the natural temptation as a surgeon. You want to be safe, so it's always easier to make things a little bigger just so you can see things. But every millimeter bigger that you make your incisions is another day in the hospital, another day that someone can get a pneumonia or some other problem from sitting around unnecessarily. And that's what this technology lets us do. But the other problem that we have with some brain tumors is when you actually look at it with your own eyes, it's sometimes very hard to tell what are you taking out. And you can imagine if someone has a tumor in important parts of the brain, let's say the movement area or the speech area, you need to be sure what you're removing. You can't tell a person before surgery, hey, come, let's have surgery, we'll remove what we think is the tumor. And the problem is that some of these tumors, they infiltrate into the surrounding brain, and that's what this microscopic view shows is that there really aren't clear boundaries. And the MRIs give you these pictures where you have this white stuff, but sometimes it doesn't really look like that when you're in there in person. It's hard to distinguish the boundaries. And what we have is we use navigation, like I mentioned earlier, that GPS system. So with that GPS system, you were even able to go really deep right into the center of the brain, into areas that were considered inoperable, and remove them. But we're also able to layer onto the navigation system functional imaging. So the colors that you see on these pictures, that's information that's acquired from the MRI machine that shows us where is speech, it shows us where is movement, where is sensation in this person. So now when we're planning surgery, we're planning it in 3D, navigating around these circuits in the brain. Because no one wants to be told, have surgery, good luck, let's see how you wake up. We kind of want to guarantee that. And this actually lets us do that. The other thing that's relatively new in the past year is these tumors. This is an example. If you look at this picture of the brain, you can tell there's a discoloration, but it's very hard to tell. Where do you make that incision? Do you cut it right over here, which is what it looks like you should be doing, but then you might not remove the entire tumor. And it's very important to remove the whole tumor. The one answer that's very difficult to implement and doesn't really work well is to get an MRI machine in the operating room. And that's the engineering and the technical issues behind that. It's a powerful magnet. It's very hard to do. But a simpler idea that came about was fluorescent imaging. We now have a substance that when you drink this substance about 2 hours before surgery, it gets absorbed by the tumor, and with a special microscope, the tumor will glow in the dark. And it's not really in the dark, it's with special fluorescent filters. But that's something that's really a simpler and easier way to remove a brain tumor. So this is an example of a woman who had a brain tumor. Actually, this is the first one that we did in New Jersey. And you can see this is her tumor glowing pink with this substance. Actually, this is a picture of them renewing their wedding vows after her surgery. But her kids had the video of her fluorescent tumor, and they took it to their science class, and they're high school students. Then other interesting things that we do is we also do a lot of surgery through the nose. So these are operations that we're doing with tiny little cameras through the nose, and it allows you to access the bottom of the skull. So, and this is an example of that GPS system. You can see how as we're moving around through the nose, the MRI scan is moving with you. It navigates with you. It shows you where you're going as you're doing the surgery. And this is a view that to me as a neurosurgeon is something that I'm not supposed to see. This is the view of the bottom of the brain looking from right underneath. This is a major artery called the basilar artery entering the brainstem. It's something we're not supposed to see because we're not used to looking at the brain from underneath. But that's what we're able to do with this technology, with cameras coming in under the skull. This is an example of a different type of tumor, the pituitary tumors that typically we will remove through the nose. And the reason we remove these through the nose is because these tumors tend to grow underneath the optic nerves. And basically it's a cause of blindness, of vision loss. This is this person's visual field from their ophthalmologist where the areas that are black, they're not seeing. So they're not seeing from the sides of their vision. This is a great story of where brain tumor surgery and treatment is going today. This is a patient of ours. We don't just say he has a brain tumor. If you look at this label, he has an IDH1 positive, MGMT positive mutant neoplasm. So what does that mean? The way we label these tumors today is no longer the traditional, labelings. Under a microscope, a pathologist thinks that these cells look like this, so we call it X. Instead, today we actually do molecular characterization of every tumor. This is stuff that's possible through gene chip technology. And every tumor gets screened. I think we now screen for about 300 different mutations within the tumor. So each tumor has its own separate molecular signature, and we actually try to direct treatment based on categories of molecular signatures. He in particular was a cool story because he had his tumor in the speech center. So we had to do his surgery awake. So here he is awake during his surgery.
The GPS system for your head, okay,
It's
bud?
me mapping out the GPS system.
Piece of tape, okay?
I'll fast forward it a little.
You okay?
Looking at the camera.
Oh, you're
Kind of
waking.
waking into the camera.
And there he is underneath
That is
the
a
tree.
mammal that's swimming.
We're testing his
What is,
speech.
what kind of mammal?
It's a fish, like a whale, but
Yeah.
it's a mammal. That's a waffle. But
You want to keep singing, bud?
Yeah, keep singing. I don't know the song, but you sound great.
What we're doing here basically is we're electrically stimulating the brain. So that's he's awake underneath, and you can't hear it here, but he's singing a song, and every time we stimulated the speaker, he stopped speaking.
Okay. I have
I'm good.
So Leanne,
On the fast forward,
that speech. Singing or no?
that's us. I think we're. No, it's okay. So this is the tumor that was removed,
Hey,
and
you want another martini or no?
he was awake.
Do ya? All right. Welcome back.
And
You're
a week
welcome.
later,
Don't thank me yet. Hold on. Sit tight.
They sang the same song. He was I think he was a Marine, and it was the song that he was singing during was a song that he wrote for his daughter. So he sent us this video clip of him singing the song. I'll stick with that.
Can't thank you enough. Thank you.
During this device to your
But what was great about his surgery was not just that it was awake. Because it was awake, we were able to remove the entire tumor. And we were able to push the limits up until, and we had this discussion before surgery. And I asked him, like, Ray, if we can remove more and it maybe gives you a little speech impediment for a little bit, is that okay with you? And his answer was just whatever would allow me to get to a cure is what I want to get to. So we did that, and his speech is fine, but he's disease-free. He's been disease-free since. And that's something we couldn't really, even today, it's hard to get to for everyone, but we certainly never imagined that 10, 15 years ago when I started doing this. Then this is just some other non-surgical things that we do. We're all shifting towards personalized medicine in the neuro-oncology realm. And that's really all about what we're doing today is either brain tumor vaccine studies. We're involved in a brain tumor vaccine study. It's something that we're all excited about and that we've tried before. There's been some successes, but it's an iterative process. It is a difficult nut to crack. And the other piece is the personalized medicine, really taking every patient and their tumor and sequencing, the genetic sequencing of each tumor so that we can find targeted drugs. The challenge here is when you get a report back that has 300 mutations, it's, well, who's going to analyze that, and how do you look at that, and how do you compare one person with another person when all their mutations are different? So that's part of why you need a real team. There are a lot of people behind that who look at this, and then and what the technology is able to do today is amazing. When you get these reports back, they don't just give you the gene mutation, they actually give you a cross-referenced article telling you, hey, for this mutation, this drug once worked in this study. So it allows the oncologist to look that up. And then we're engaged in a number of national clinical trials. We're always trying to beat these tumors, and a lot of them, unfortunately, are not beatable. A lot of them, unfortunately, we lose our patients eventually to some of these tumors, and we're always trying. I think that was most of my talk.
Well, Dr. Moshel, thank you. Great presentation. He came in his scrub. He's ready for action. So I'd like to nominate someone for a brain transplant. So I think Donald Trump needs a new brain. And the question is, whose brain does he get? My wife would nominate Ruth Bader Ginsburg. My personal favorite would be Rosalind Carter. So I think you guys should work on that stuff. Next. All right, so my question is, about a month ago on 60 Minutes, they had a doctor in West Virginia who treats Alzheimer's symptoms with microwave energy. He gets, and what happens is they map where the plaques are. Is that what it's called, plaque? They give them the medicine for the Alzheimer's, and the microwave energy, I guess, moderates the brain-blood blockage or interface. So can you tell us a bit about that? And then another offshoot of it is that they're treating addicts with it. So they get the addicts in the MRI, and they show them pictures of needles and drugs, and then it lights up the part of the brain that promotes this sort of thing, and they've been treating addicts. So can you comment on that kind of stuff? Thank you.
Yeah, the doctor in West Virginia who you saw is actually is a friend of mine from training. Right. Sorry, he's a friend of mine from training. If you remember when I mentioned the fluorescent imaging, one of the things that they found is they're finding compounds that selectively enter different parts of the brain. We don't totally understand how or why it works, but that substance that's used for the fluorescent imaging gets selectively taken up by the brain tumor cells. And so one of the initial idea was, well, if we get something that can get selectively absorbed by these cells, instead of just using it to visualize, why don't we use it as a way to selectively target these cells? And one of the things that they found out is that that substance is actually an ultrasound modulator. So there's something called focused ultrasound, where you can deliver high strength, very focused ultrasound signals to parts of the body. And they have devices where you can actually make lesions, like very accurate lesions within the brain, just like the CyberKnife machine does without actually making an incision. You can do that with a focused ultrasound device. The next step was to say, well, gee, if I delivered a ultrasound wave diffusely to the brain, maybe the parts of the brain that took up this substance will react more. And that's what they're doing. They're actually now studies using focused ultrasound with this substance, and the ultrasound's kind of delivered to the entire brain, but the substance that gets selectively taken up by the tumor cells is what focuses the energy into the tumor. So if you take that idea and now you add it, and you can use it for anything, and one of the things is for Alzheimer's plaques. It's a generalized ultrasound that's delivered, but the ultrasound is focused by the chemical that the person's ingesting. And I think these are all things that in the next decade will materialize into treatments.
Thank you for your presentation. You may not know me, but I know you well. You don't know my brain, but I've seen a lot of your cases where you've been going through complicated paths to go to the skull base and be able to remove those tumors. So for the ones who don't know Dr. Moshel, I can tell you he's a fantastic surgeon. Not only is a good speaker, but he's a fantastic surgeon. The reason I know all that is my partner is a giant lean.
Oh,
So my partner would come back and say, "Oh, I did this case with Yaron, and it's come and take a look." So we go on the computer. He shows me all those tumors, and Giant was getting very excited working with you. So sorry about the personal things here. My question is, all that technology, how much has it increased the survival? We measure tumors in a 5-year survival. Can you tell us a little bit, has it changed much?
So,
Thank you.
thank you. But the person he's referencing, Dr. Lin, is a fantastic surgeon, and he works with us to do the operation that we do through the nose, like all the skull-based operations through the nose. Dr. Lin has been great. We've been working together for years now. Thank you. To answer your question about survival, it depends on which tumor. The biggest impact that we've seen is with metastatic tumors. So these are tumors that originate elsewhere in the body and spread to the brain. If you go back many years, the treatment was always whole brain radiation, which was a crazy idea if you think about it. You were radiating someone's entire brain. But when that was developed, it was a palliative move because the survival was not good. Today, as primary tumor treatments have increased, and we're seeing it with, for example, with melanoma, with lung cancer, with the development of immunotherapies, our ability to control these tiny little tumors that spread to the brain has become really important. And with that, we've really increased survival in metastatic disease. The other category of common malignant brain tumor is glioblastoma. And glioblastoma still remains a challenge. The survival with glioblastoma, which is a very aggressive cancer that begins within the brain, within the glial cells of the brain, that's the tumor that Senator Kennedy had, that's the tumor that John McCain had. It's still very hard. We've pushed the envelope a little bit, but the progress that we've made is on the order of months of survival, not years of survival. So those tumors still remain very difficult. We still see about 18 months of survival for those particular tumors, despite everything that we try.
Thank you for a great presentation. 2 quick questions. Regarding glioblastoma, I think it is, what is the current thinking about the cause of that? Is it genetic, microorganism, metastases, or whatever the case is that's the most lethal? And the second thing, I'm just a little bit of history. My understanding originally is that taking a tumor out surgically, the problem was, as you kind of alluded to, is you couldn't get it all. Now, can you share with us how that has improved given all of this technology that you're talking about? Is it more or less down to a very small number of tumors that are not totally removed, or is it still a wide variance? Those 2 questions.
Sure. In terms of removing the tumors, the tumors benign tumors we can remove completely, and that's often a cure, and that's something we do all the time. Same with pituitary tumors or acoustic neuromas. It's less of an issue over there. The malignant tumors, it's very difficult. It's not like the colon, let's say, or the breast, where you can remove a margin of tissue around something. That margin of tissue is your brain. And these cells tend to infiltrate, especially with glioblastoma. Glioblastoma, if you do a biopsy a few inches away from where the tumor margin ends, if you look carefully, you'll find 99% normal brain cells, but you'll find a tumor cell that has snuck in there. So when we talk about removing glioblastoma, we're really defining it by MRI. On the MRI, it looks like you removed it all, and that's what we call a gross total resection. But that's still not really a complete resection. Biologically, it's not possible. And that's why we need all these other treatments. The cure for glioblastoma is not going to come from surgery. It's going to come from targeted therapies. And when we say something is removable, we kind of define that by what's going to make biologic significance. So if we know that we're not going to be able to remove more than 50% of a tumor, we actually know that it's not worth removing it. You're better off just doing a needle biopsy. To make an impact on removing a tumor, a malignant tumor, you really have to cross that 80% even 90% threshold. And that's what we strive to do when in removing these tumors.
Can you hear me?
Walt,
Can you hear me?
yes.
Okay. In 1990, at age 68, my mother had astroglioma that was centered over the base of the brain stem. And so I was wondering, I sort of follow all the uh, advances since then, but uh, because of the blood-brain barrier, chemotherapy is ineffective. They tried whole brain radiation. Of course, that's not targeted. Um, so, I mean, you sort of talked about it a little bit, but I was wondering exactly what could be done today. And the other thing I was wondering about is there's things like PDL1 mechanisms to handle metastatic cancers. And I was wondering if they've done anything along those lines.
Thank you, Walt. I could only see some of we couldn't hear you well, but I think I got some of your question. The last thing you asked about PDL1 receptors. PDL1 receptors are the receptors that a lot of the immunotherapy drugs work against. So I'm sure you've all seen commercials for Opdivo or Keytruda that are very common now. Those a lot of them work through attacking the PDL1 receptor, which basically is these are drugs that turn off the natural brakes that we all have on our immune system. So the reason your own immune system doesn't attack yourself is we have these natural brake mechanisms, and they work through that PDL1 receptor. And these drugs like Keytruda or Opdivo, that's what they do. And it's been great for some tumors, like in certain types of lung cancer. In general, that avenue has not worked for brain tumors. And we've tried many different ways of doing it. We've even tried giving PDL1 inhibitor drugs into the spinal fluid. We've tried it with radiation. Just glioblastoma does a good job at suppressing the immune system, and we have not had a lot of success with immunotherapy with glioblastoma. Now, the other thing that you mentioned, Walt, was I think you said it was your mom had a brain tumor on the brainstem. The one thing we've learned about tumors along the brainstem is they actually have a different molecular signature. And we're involved in a study now that targets the molecular signature for these brainstem tumors. They're called diffuse midline gliomas. That's the name of that category. And they actually are accompanied with a very specific mutation that now they're producing a drug to target that.
Fantastic talk, very interesting. I've got two easy questions, short. One is, how does a tumor metastasize into the brain through the blood-brain barrier, or isn't it cells that are metastasizing? The other is, I have a kid brother who was the black sheep of the family. He was really a mess. Angry, violent. Somehow he survived till he got out of the Air Force, and they found a brain tumor and took it out, a benign one. And he turned into a real sweetheart. Now, I imagine a change in pressure on the brain and stuff affects all kinds of things, like your vision you mentioned. Could you comment on those two things?
Sure. I think how tumors metastasize, metastatic tumors spread to the brain, usually it's through the bloodstream. There are also tumors that spread into the brain through the venous plexus of the spine. So the veins in your abdomen are all connected to the veins in your head. But typically, the thinking is that they spread through the bloodstream, right? So a tumor cell will enter the bloodstream and lodge into a little capillary in the brain. a lot of these tumors, different tumors have different predilections to get to different organs in the body. For example, colon cancer almost never goes to the brain, or if it does, it's very late in the process, whereas lung cancer goes to the brain super early. And a lot of that has to do with different homing receptors on the cell surface of these different tumors. But it's generally through the bloodstream. In terms of personality changes in brain tumors, we see that all the time, especially with tumors in the frontal lobes. We see people present with symptoms where the family thinks that they're just changing, they're becoming more removed or separated from the family, or less engaged socially, and that's actually a common symptom for a frontal lobe brain tumor. So we do see personality changes. It's a little unusual with benign tumors, so I don't know exactly what happened with your brother, but it certainly wouldn't, it's not unheard of. It wouldn't surprise me.
Thank you.
Sure.
We have some questions online in the chat.
Does this doctor operate on cavernomas? Cavernous malformations are little vascular malformations in the brain that can bleed. And yes, that's something that we do surgery on. Has this technology given neuroscientists insights on consciousness and where it's produced in the brain? You know, the answer is no. That's still, I mean, we have a much better understanding of consciousness, and you know, the way we look at consciousness today is it's really a diffuse network throughout the brain, right? It's not, and when we see people have symptoms from different problems, you can see that different components of their consciousness are affected. And we're learning that consciousness really is a component circuit, right? And there are big circuits, and then there are accessory circuits. And it is interesting, but that's something that we're still learning about. But we now are able to do these MRI scans where we can actually look at the baseline activity of all the neurons in the brain. It's called a resting state MRI. And it's really interesting how all, you know, these neurons all fire in synchrony, and sometimes they're totally out of sync. And this can change based on your attention span or what activity you're doing. And we're learning more and more about different common circuits in the brain and how they affect consciousness. But that is still something we're learning about. Someone asked, I have a meningioma high in the brain. It is not growing since last year. What are the risks of removing such a benign growth? In general, the answer is if it's a benign tumor and it was just found, you shouldn't, you know, unless it's gigantic, you really shouldn't do anything about it. If it's a benign tumor, sometimes those don't grow, and we monitor it. I always tell every patient with benign tumors that were found incidentally, you know, this is the Polaroid snapshot. We're interested in the movie. So you need a few more MRI scans to see how is this going to behave over the next several years before you make a decision about removing it. A lot of times you don't have to remove it. I would say probably most of the time you don't.
Very fascinating presentation. You mentioned that the fluorescent dye that is being used was not something you understand how it works, and it sounded like it was a serendipitous discovery. How was that found?
It was found by a neurosurgeon in Germany. Walter Strummer is his name, and he was doing a lot of research on protoporphyrins, which is it's a compound that's part of the biology of our mitochondria in our cells. So in the mitochondria of the cell, which is where where cells produce energy and create ATP, as one of the byproducts is something called protoporphyrins, and those are chemicals that naturally fluoresce. And I think he spent the last 15, 20 years studying this and trying to find compounds that did this. It was his vision, and I remember when he first published this, and it was something he was trying in Europe maybe 7 years ago, everyone thought he was crazy. But it's because of him. And there is, there's a whole set of compounds, biologically active compounds that naturally fluoresce. And that was the angle that he took. Now, why this gets taken up specifically by brain tumor mitochondria is what we still have to understand. We don't understand that fully well.
Very, very informative talk. Yeah, one thing you mentioned was it Giant Land from Summit Health?
Yes, yeah.
No, I've seen him for, I have a deviated septum.
Okay.
We haven't had surgery, but question, how would you discover somebody has a possible brain tumor? Is it through blood work, or how do you discover it?
It's all discovered, brain tumors today are all discovered with MRI scans. You know, people have symptoms and eventually that leads to an MRI scan. We wish there was a way to diagnose things earlier. There were some people who tried to get insurance companies to get mobile MRI scans, to do screening MRIs, and that never panned out. There's still a lot of research into the idea of liquid biopsies for brain tumors. So whether, you know, on a blood test, if you can find fragments of the DNA of a brain tumor and perhaps detect it on a blood test. But that's being developed in other tumors. It's not quite there for brain tumors just yet.
My cat.
I have a relative of age over 70 who recently began acting strangely, including having hallucinations. Could this be due to a brain tumor? Should she have a scan? It could be due to many things. You know, brain tumors are still relatively rare things in the community. So when someone starts having hallucinations, eventually they probably should get an MRI, but they should see a neurologist first to really get a workup. You know, sometimes it could be something simple related to medications, but you really want to study everything. But eventually they might end up getting a scan.
Thank you. In 1976 and 1986, my mother had brain surgery at Overlook. I'm sorry, I can't remember the doctor's name who was so prevalent back there. Yeah, it actually holds section. Anyway.
I wonder if it was Dr. Hodash back then.
Might have
Does
been.
that sound familiar?
I think there was another one. Anyway, just to show you what has changed, when she came, she had a tumor the size of a lemon, and they had a big horseshoe cut in her head. And that's how different it is today versus then. Anyway, my question, how do you know when to use CyberKnife versus some invasive procedure?
So we have a whole team. We work closely with a radiation oncologist. You know, I think I know the indications for CyberKnife. It's something that really needs to be evaluated by a surgeon and the radiation oncologist together. The first basic answer is size. Generally speaking, if you're going to treat something with CyberKnife, you want it to be less than 3 centimeters, ideally less than 2 centimeters in size. You also don't want a lesion that has a lot of swelling around it, because when you're going to zap it with radiation, it's going to only swell more. So some smaller lesions usually don't have a lot of swelling, and you can treat those with CyberKnife. If you have a lesion or a tumor that has a lot of swelling around it, you're probably better off removing it as opposed to doing CyberKnife. So those are the factors. It's size, location in the brain, and whether there's a lot of swelling in the brain.
Fabulous, fascinating work. We have to thank you for being a pioneer in this area and having it in our area for us. I have two questions. I'll ask them both and then sit down. One is, I haven't heard you say anything about chemotherapy. So the question is there or has there ever been any kind of chemotherapy to as an auxiliary to brain surgery or instead of? I could imagine that chemicals in the brain aren't a good thing, so maybe the answer is no. And the other question is, maybe this is just semantics, but I'm a little puzzled. You talk about removing things that are deep inside, and yet you're doing things with beams and tiny probes. When you say remove, do you always mean extracting the affected tissue, or do you also are you also saying you just kill it and leave it in place? And by the way, I don't see how you can use a tiny probe to extract a large amount of tissue. Tell us about that. So
chemotherapy, no, there is chemotherapy. I'm Unfortunately, when we reference chemotherapy, usually we're talking about glioblastoma, which is the type of tumor I mentioned earlier that's still been very difficult to make progress on in terms of survival. The chemotherapy for glioblastoma has been about the same for the last 15 years. It hasn't really evolved a lot. So there's a drug called Temodar. It's nice because you can give that chemotherapy as a pill as opposed to an infusion. And then the second line treatment is an infused drug. It's called Avastin. And that's pretty much standard of care today for glioblastoma. In terms of removing tumors, yes, when I say remove, I mean remove. We actually are extracting this tumor out. It depends. Superficial tumors, it's actually very important. We try to keep the tumor intact in 3D. We try not to break it up. But those are things that are accessible on the surface. Deep-seated things where we're removing them, let's say through the nostril or through the nose, you have no choice. In that scenario, you have to break it up into smaller pieces in order to remove it because the instrument you're using is like the diameter of a straw. So you are breaking it up and removing it that way for things where you're removing them through the nose or minimally invasively.
Yes, thank you. It's very fascinating. The question I have is about how much AI has been used so far in your surgery and what you think the future looks like as far as use of AI.
Thank you. We've been using AI a lot in imaging, in radiology. So one of the early uses of AI in neurosurgery has been when we're trying to detect if someone had a stroke. So when someone shows up to the hospital and they get a CAT scan, there's a lot of processing that has to go on to identify whether there is salvageable brain tissue with an intervention or not, if someone had a stroke. Because in that scenario, time is brain, and you don't have time to call a human radiologist and have them look at it and analyze the pictures and waste too much time. And that today is pretty standard that those images are initially interpreted. I shouldn't say interpreted, but the results are made very easy for the surgeon to interpret by an AI platform. So that's something that's in active use today in stroke neurology, right? In neurosurgery and in brain tumor surgery, the places where I see AI naturally fitting in is, if you remember those pictures where I showed you of the brain tumor, of the brain, identifying those margins and identifying those edges and putting together the MRI data with the fluorescent data and kind of showing the surgeon, this is probabilistically the best place to make your margin incision, and it's safe. A lot of that is stuff that we do naturally today, I do naturally, but how do you teach that to a younger person? It's very difficult, and I could see AI being very useful with that. The other place where AI is gonna have a role is in pathology. Analyzing all these slides and analyzing all the mutations that we get and trying to come up with sort of digestible, logical subgroupings of all this information, right? So analyzing all the informatics that we get today is going to be another role for AI.
Our last question, please. Thank you very much. Wonderful. Wonderful talk. Thank you. Doctor, what's the difference between gamma knife procedure and cyber knife?
They're practically the same thing. Gamma knife is an older machine. They do the same thing in that they deliver focused radiation to a pinpoint spot within the brain. Today, the machines look very similar. When it first started, the way the gamma knife made sure that you're zapping the right spot was by essentially, the neurosurgeon would screw a halo around your head into the skull, and your head was immobilized, so you're attached to the table, and the radiation, there was no question, it was accurate, it got to the right spot, you can't move your head. The cyber knife, Instead of doing that, what it does is they use a mask that you can pop on and off. It's like a mesh, plastic mask that you can see through and breathe through, and that holds your head in place. The problem with the mask, though, is you can still move around inside the mask. You can wiggle a little bit. And what the CyberKnife platform does is they have live imaging. So they have 2 X-rays coming in from 2 different angles, and the computer system can interpolate and calculate on the fly whether you've moved at all, and it'll adjust with you. So it's more user-friendly in that it has a mask as opposed to bolting a halo onto the head. The newer Gamma Knife machines now have gone to the mask as well. So these technologies are coming together and they're looking more and more alike. I would say today it's practically no difference. The CyberKnife and the Gamma Knife are extremely similar. They're just different manufacturers.
So, thank you very much. I was going to say it was a fascinating presentation, but about 6 or 7 other people have already said that it was a fascinating presentation, but it was certainly amazing. And I sincerely hope that nobody in this room or on Zoom ever needs to see you professionally. But if they do, I think all of us will be very glad that you or people like you at Atlantic Health are there. So I'd like to present you with just a certificate of appreciation.
Thank you.
And if you would please show your appreciation.